Hi guys, welcome to the fifth podcast of cardiology, and today we are going to talk about mitral valve diseases. So we will mainly cover mitral stenosis, mitral regurgitation and mitral valve prolapse. Before starting with diseases proper, let's talk about mitral valve apparatus. Okay, so there are basically 5 components of the mitral valve apparatus: annulus, leaflet, chordae tendineae, papillary muscle and the myocardium. Okay, the myocardium where the papillary muscles are attached. Right, so annulus is a elliptical structure to which the leaflets are attached. Okay, so annulus we divide it into anterior part and posterior part. Anterior part is fibrous and posterior part is muscular. Leaflets, again we have two leaflets, anterior and posterior. Anterior leaflet is thicker and larger, whereas posterior leaflet is thinner and smaller. Okay, then there are chordae tendineae which attach the leaflets to the papillary muscle. So their chordae tendineae are around 25 in numbers, and then we have papillary muscles. So papillary muscles, again we have two groups: anterolateral group of papillary muscles and posteromedian group. So anterolateral group has dual blood supply, but posteromedian group has only one blood supply, either from right coronary artery or from left circumflex artery, either one of them. So in case there is inferior wall MI, right, so there can be decreased blood supply to this posteromedian group of papillary muscle, and then there can be inflammation, necrosis, and finally rupture can occur. So posteromedian group of papillary muscles can get ruptured easily as compared to anterolateral. Now let's come on to the MS. So as you all know, the rheumatic heart disease is the leading cause, or this is the most common cause of MS, and other causes can be SLE or rheumatoid arthritis, okay, or any other congenital anomalies. Now the normal surface area of the mitral valve is around 4 to 6 cm square. But when the area becomes less than 2 cm square, then this mitral stenosis becomes significant. Okay, so we have categorized mitral stenosis into various grades, into mild, moderate, severe, and one of the criteria for deciding that is the surface area. So if the surface area is more than 1.5 cm square, okay, then it is mild MS. If it is 1 to 1.5 cm square, then it is moderate MS. And if it is less than 1 cm square, then it is severe MS. Okay, and this is one criteria. The other criteria is pulmonary pressure, pulmonary artery pressure. Okay, so if the pressure is less than 30 mm of Hg, so normal is maximum is 25 mm of Hg. If it is less than 30, then it is mild. So in mild, there is as such no pulmonary hypertension. In moderate, the pressure is 30 to 50 mm of Hg, and in severe, the pressure is more than 50 mm of Hg. Okay, this is in pulmonary artery. So what is the significance of dividing mitral stenosis into various categories? So we will see further, but in mild category, the treatment option we prefer medical treatment, and if it is moderate to severe, we need to go for medical as well as surgical. Okay, now let's talk about mild. So mild MS, only symptom is dyspnea on exertion. Okay, initially only the symptom is dyspnea on exertion. Why do we get dyspnea on exertion? See, normally mitral stenosis is like a narrowed door or narrowed passage for the blood to go into the left ventricle. Okay, if the heart rate is normal or if it is bradycardia, then the diastolic time is longer and left ventricle can get filled enough. But in case the person is exercising or the heart rate has been increased, the diastolic period decreases. If the diastolic period is decreased, ventricular filling will be decreased, and the blood will accumulate in the left atrium, and by the back pressure there will be increase in the pulmonary venous pressure, and there can be pulmonary edema. Okay, so this can lead to dyspnea, but this dyspnea is only on exertion. Okay, and pulmonary artery pressure and cardiac outputs are normal in mild MS. Now if this MS progresses and goes to moderate MS, then the pressure or the dyspnea which is there, it also occurs at rest. Okay, so left atrial pressure is increased at rest, therefore there is pulmonary venous pressure and increase in pulmonary venous pressure, and due to back pressure, pulmonary hypertension can also occur. So we have seen it is around 30 to 50 mm of Hg. Okay, due to this pulmonary hypertension, this pulmonary hypertension can lead to right ventricular hypertrophy, right? So remember, left ventricle is the last one to get affected in MS. Okay, first left atrium is affected, then the pulmonary system, then right ventricle, then there is signs of right ventricular failure, and after that left ventricle is affected. Okay, so never say left ventricle is affected in MS. Right, so now we have seen that there is right ventricular hypertrophy, and since there is increased pulmonary artery pressure, we can get palpable P2 sound. Okay, because now the right ventricle has to pump against a lot of pressure. Okay, and because of right ventricular hypertrophy, the JVP will be raised. Okay, and one more thing that can happen due to right ventricular hypertrophy is functional tricuspid regurgitation. Okay, so due to tricuspid regurgitation, we can get V wave, the CV wave, which we talked about in JVP. That is also possible in moderate and severe MS. Okay, and since due to moderate MS, there is dilatation of the left atrium because of increase in pressure, there can be scarring of the tissue, of the atrial tissue, and ectopic foci can be formed, which can lead to atrial fibrillation. Okay, so we need to monitor for atrial fibrillation. We need to keep on checking pulse. If the pulse is irregular, then that is suggestive of AFib. Okay, and in severe MS, we get all these signs of moderate MS plus signs of right ventricular failure like ascites, edema. Okay, and in very severe MS, left ventricle is affected, but that is very rare. Okay, now let's sum up all the symptoms of MS. So the first and the most important symptom is dyspnea. Then the patient can get palpitation if atrial fibrillation is present. Then hoarseness of voice, since the dilated left atrium can compress on the recurrent laryngeal nerve. Then due to pulmonary artery hypertension, orthopnea, PND is possible, hemoptysis, okay, and right ventricular failure, signs of right ventricular failure. Okay, now coming on to the heart sounds and murmur. So in MS, there is loud S1. Why there is loud S1? We have talked about this. Let's revise. So in MS, the leaflets of the mitral valve are widely apart. Normally, if there is no MS, the valves are semi-closed. Okay, so before closing, they are not very far away. So the S1 sound is normal. But in MS, since already the space is narrow, these leaflets move far apart. And when the ventricle contract, these leaflets come from this far distance and then they close. That's why we get loud S1. Okay. The other sound is opening snap. Okay, this is mostly whenever you hear opening snap, it is almost always due to MS. Okay, opening snap is due to buckling of the rigid valves which have fibrosed. Okay, which have thickened. So before opening, these valves buckle and this causes opening snap. Okay, and there is a thing called S2 to OS interval, and depending on this interval, we can judge the severity of MS. So lesser the interval between S2 and OS, more is the grade of MS, more severe is the MS. Why do we say so? Because see, S2 is because of closure of aortic and pulmonary valves. Okay, so after the pulmonary valve close, when the ventricles are relaxing, the pressure in the left atrium is increasing. Okay, more severe the MS, mitral stenosis, more will be the pressure in the left atrium. Okay, so if the pressure is more, the valves will buckle or the opening snap will come early. If the MS is not of very severe grade, then the pressure in the left atrium will not be very high. That's why opening snap will come later. So severe MS, S2 to OS time gap is lesser. Mild or moderate MS, S2 to OS gap is wider. Okay, and murmur, which type of murmur do we get here? So it will be mid diastolic murmur, right? Because most of the ventricles is getting filled during the diastolic phase. Okay, rapid filling phase. So it will be mid diastolic murmur. And so since this is a diastolic murmur, it is a low pitched murmur. Okay, and what are the characteristics of low pitched murmur? So low pitched murmur is restricted to a particular area. It's not radiated. then there is associated thrill, okay, and it is rough and rumbling type. High pitch murmur is musical, but low pitch murmur is rough and rumbling type, and we hear it with the bell of the stethoscope. Okay, so and one more thing in MS is pre-systolic accentuation. That is because the active filling phase, when the atrium actively contracts and fills the ventricle, at that time, just before the ventricle starts systole, there is accentuation in the murmur. So that is pre-systolic accentuation. Right. Now, what are the other associated murmurs that are associated with MS? The first one is tricuspid regurgitation, which we have talked about. There is functional TR because of right ventricular hypertrophy. So that is known as Carvalho's sign. Okay. And in tricuspid regurgitation, murmur will be pansystolic throughout the systole. And in ECG, we will get the finding of P mitral. Okay. So on the lead 2, we will get bifid, or the 2 peaks we will get, because left atrium is now enlarged and thickened. So on the ECG, the contribution of left atrial electric impulse will be higher. So first there will be a peak due to right atrial depolarization or pulse or impulse in the right atrium, and then the second peak will be due to the left atrium. So on ECG we will get P mitral. Now how do we manage this condition? Manage MS. First we grade MS depending on based on echocardiography, and the main thing that we have to do here is prevent tachycardia. Tachycardia is harmful in patients of MS. So we give beta blockers, we give diuretics. Okay. If there is associated atrial fibrillation, there can be increased chances of thrombus formation. So we start this patient on warfarin and maintain their INR between 2 and 3. Okay. So this is general medical management, only medical management, which we prefer for mild MS. But if it is moderate to severe MS, then we need to intervene. And in intervention we do percutaneous balloon mitral valvotomy. Okay. Here we introduce a catheter, then we enter the right atrium. We puncture the interatrial septum, we enter the left atrium, and then we insert that cannula in between the valve of mitral valve, and then we inflate the balloon. Okay, so there is correction of MS. What are the contraindications of this percutaneous balloon mitral valvotomy? Two contraindication mainly. One, if there is associated MR along with MS, and if there is thrombus present. If there is atrial fibrillation and thrombus is already present in the left atrium, then we avoid doing this intervention. Okay. And also if the valves are calcified, then we need to go for repairing of the valves or replacement of the valves. If there is contraindication for PBMV, then we need to go for repair and reconstruction of mitral valve. Right. So this was about MS. Now coming on to MR, mitral regurgitation. So we have seen in the mitral valve apparatus, there are 4 to 5 components of mitral valve apparatus. So if any of this is damaged, then it can present with MR. So either valves can be affected, the leaflets of the valves can be affected, the annulus can be affected, or the papillary muscles can be affected. So valves are affected in rheumatic heart disease and in myxomatous changes. The annulus is affected if there is dilatation of the left ventricle, and papillary muscle rupture can occur if there is inferior wall MI, okay, or there is myxomatous degeneration. So any of these conditions can lead to MR. Now MR we divide into 2 depending on the duration, acute and chronic. So acute MR can be due to papillary muscle rupture or due to trauma, and chronic MR can be because of myxomatous changes, rheumatic heart disease, okay, left ventricular dilatation or dysfunction. So symptoms of acute and chronic MR are slightly different, or they are mostly different. Why? Because in acute MR, left atrium is not used to accommodate so much blood. Okay, and if there is sudden MR, then left ventricle, which will pump the blood into the left atrium, but the left atrium is not compliant. It is not able to accommodate so much blood. So it will lead to fast increase in the back pressure, and it will lead to increase in pulmonary venous pressure, it will lead to edema. Okay, and here here the left atrium is not compliant. That's why there is sudden rise or sudden worsening of symptoms. Whereas in chronic MR, the left atrium becomes compliant, so it can accommodate most of the blood which left ventricle is pumping into it. So the signs and symptoms of increase in pulmonary venous pressure and edema are lesser, okay, or are delayed, right? And murmur in acute MR is early systolic murmur, okay, because whenever the left ventricle is pumping the blood, initially it will pump blood in the left atrium, but once the left atrium is full, it has to pump the blood in the aorta, right? So we will get early systolic murmur in acute MR, but in chronic MR, since the left atrium can accommodate a lot of blood, we will get a holosystolic or pansystolic murmur. So let's talk about pathophysiology of MR. So when the left ventricle is contracting, some amount of blood is going into the left atrium, but the aim is to maintain the cardiac output. So to maintain the cardiac output, the left ventricle has to hypertrophy. So there is eccentric hypertrophy, but there is also dilatation of left ventricle because now more amount of blood is coming. So initially left ventricle maintains the cardiac output to around 65 to 70%. But if we do not treat this condition, if it is for chronic period of time, then eventually there will be left ventricular failure and cardiac output will decrease. Okay, so initially the patient may be asymptomatic. Okay, there will be no chest pain, no dyspnea, no syncope, and only thing initially patient can present with is palpitation because the ventricle has to pump with a lot of force. So the patient can get aware or will be aware of his or her own heartbeats. So initial symptoms will be palpitations, but later when there are signs of left ventricular failure, the patient can present with fatigue or hypotension, okay, when there is decrease in cardiac output. So on examination, what all do we find here? We get hyperkinetic pulse, okay, because this is a overall increased volume or volume overload state. So we will get hyperkinetic pulse. If we see on inspection, we see the apex of the heart, it will be hyperdynamic or dancing apex, okay, and apex will be deviated down and out. Now on auscultation, heart sound and murmur. So in heart sounds, S1 will be soft because there is MR, no? So the mitral valves are not closing properly, so the sound S1 will be soft. S2 will be, there will be wide split in S2, okay. Why wide split? Because there will be early A2 and delayed P2. Early A2 because ventricle is pumping the blood in the aorta as well as in the left atrium, so it will get emptied faster. So A2 will come earlier, and P2 will be delayed because there is increase in pulmonary hypertension. There is pulmonary hypertension and the right ventricle has to contract against this high pressure. So P2 will be delayed. Therefore, we will get S2, wide split of S2, and it will be variable. It will vary with inspiration and expiration. We can also get S3 sound because it is a volume overload state. Okay. Now systole the murmur in MR is pansystolic murmur because mostly in chronic MR. In acute MR we have seen it is early systolic, and in chronic MR the murmur is pansystolic. Since this is a systolic murmur, it is a high pitched murmur. And what are the features of high pitched murmur? It radiates and it is heard with the diaphragm of the stetho, right? Thrill is absent, okay, and it is a soft blowing and musical murmur, right? Now when do we call MR as severe MR? So there are three criteria. First is if any of these three criteria is present, then we call it a severe MR. So these criteria are if the volume of blood, regurgitant volume of blood is more than 60 ml per beat, or is more than 50%, or if it is more than 50%. So 50% of it is entering the left atrium and 50% is going in the aorta, then we will call it severe MR. And if the orifice of regurgitant orifice is more than 0.4 centimeter square. So in these conditions we will call it severe MR. So how do we manage this? So we first see whether the MR is non-severe or severe. If the MR is non-severe, then we just monitor. Okay. If it is severe, then we see whether it is symptomatic or asymptomatic. If it is symptomatic, then we check the ejection fraction. If the ejection fraction is more than 30% and the patient is symptomatic, then we go for repair, mitral valve repair, and this repair is most of the time successful. Okay. If it is severe MR, symptomatic severe MR, but the ejection fraction is less than 30%, then we can go for repair, but the outcome or the effectiveness of the repair is questionable, but the repair is still recommended. Okay. Now, if the MR is severe, but the patient is asymptomatic, then we see whether the patient is young or old. If the patient is young, we go for repair. If the patient is old, then we just monitor. And what do we monitor? We monitor ejection fraction. If the ejection fraction is decreasing, then we go for repair. Okay. So this is the overall management. And if it is secondary MR, that is MR due to heart failure, then we need to manage the heart failure. Right. Now coming on to the last topic, which is mitral valve prolapse. So in mitral valve prolapse, there is displacement of the mitral valve leaflets. These mitral valve leaflets are abnormally thickened, and there is displacement of these leaflets into the left atrium during systole. Okay. And this displacement is of more than 2 mm. Okay. The primary pathology in MVP is myxomatous degeneration. What exactly is myxomatous degeneration? So there are like inflammatory processes going on in the valve. Sorry, the processes which are occurring, they are non-inflammatory, but the glycosaminoglycans which are there, they are abnormally increased. Okay, and the extracellular matrix also is abnormal. So because of this, there are spongy changes in the leaflets. Okay, and posterior leaflet is commonly affected in MVP. These myxomatous changes can also affect the chordae tendineae and papillary muscles also. Okay, and MVP occurs commonly in patients with Marfan syndrome or with Ehlers-Danlos syndrome. So one important thing in MVP is the murmur. Okay, so in all heart valvular diseases, whenever there is increased amount of volume coming in the left ventricle, the intensity of the murmur increases and the duration also increases in most of the conditions. But in mitral valve prolapse, the condition is opposite. So whenever a patient stands or performs Valsalva maneuver, the amount of blood coming in the heart is lesser. So we may think that the intensity and duration of murmur will increase, but it decreases. Why it decreases? See, basically MVP is like a door which is closed, and to open it we will need a larger amount of pressure. MR is not like that. In MR the doors are open. We just need blood. There. The blood can easily go in from the left ventricle to left atrium. But in MVP the doors are closed. We need a certain amount of pressure for these valves, so that these valves open and there is regurgitation of blood. So if the volume of blood is lesser in left ventricle, it will have to pump with a greater velocity, or the force of contraction has to be greater to maintain the cardiac output. Okay, so if the contraction force is greater, the mitral valve will prolapse and there will be more regurgitation, and the regurgitation will be for a longer duration of time. Okay, because force of contraction is more, right? One more thing is that if the volume is less, if the volume of the left ventricle is less, if the blood filled in the left ventricle is less, the chordae tendineae and papillary muscle will be lax. They will not be stretched. And this is one more factor because of which mitral valve can get prolapsed if the volume is lesser. Okay, so the main important point out of this is the intensity and duration of murmur of mitral valve prolapse increases with standing and Valsalva maneuver. Okay, right. So that's all about MS, MR and MVP. Chalo. Bye bye.